Welcome to Belly to Baby, or From Belly to Baby. I think one of these days I'll actually get the title of this segment correct. I am Abby. I'm here with Dr. Jackie Turner. You can't really tell it, we've moved out of the Barnes Jewish Washington University campus, and we are now out in the community. And we're at West End OBGYN today with Dr. Turner. Thank you so much for letting us drop in.
Of course. I'm glad to have you.
You are a little less busy, I'd like to say, than you used to be. Dr. Turner just retired from her OB practice. She still has a gynecology practice here at West End, but we were just asking you the number of babies you delivered, and you said roughly?
About 5,000 over the last 30 years.
5,000 over the last 30 years. So I think as questions arise, she'll have a few answers for us. In fact, we were just talking, I feel like this segment is very self-serving in so many ways because I'm able to get a lot of my questions answered. And Dr. Turner, you came in and asked immediately if I had felt the baby move yet, and I'm at 18 weeks. And I said, between 16 and 17, I've been paying very close attention, just kind of to the thoughts, to the things I'm supposed to or maybe able to feel. And at that point, there was a flutter that I said, I feel like I swallowed a goldfish, like something was moving, but I couldn't quite figure out if it was a baby. And now I feel stuff occasionally. You said that's normal, but...
Right. So movement typically starts around 18 weeks, but we usually hear a variety of things from people because women who've been pregnant before tend to feel it earlier.
Is it because they know what to look for,
or is it because they know what to look for?
Okay.
The movements can be very subtle until you get further into the pregnancy. So at 18 weeks, you're not feeling kicking. You're just feeling sort of general squirming. It usually feels like flutters.
I'll say generally invaded would be kind of another, like there's something there that wasn't there before.
Well, just wait if you think it feels that way now, because that's going to get more pronounced as the baby gets bigger.
I remember my mom saying this always creeped me out to such a degree that she said the best is when you can see an arm move across your stomach.
You will.
Okay.
It reminds you of that movie Alien.
Yes, that's what it sounds like anyway.
It is.
Well, as unpredictable as when those movements begin, and we can kind of target a time frame, the one thing that is very predictable about pregnancy now and treatment in OBGYN clinics tends to be the number of tests that we get along the way. And I don't know about everybody else, but you go into that first OB appointment and it's overwhelming in so many ways.
There is a lot of material cover. We ask you a million questions. I bought one of our blank paper forms. There's a million questions, and there's a lot of stuff to discuss, and then there's a lot of testing that we order. I know when people go to the lab, they come back and they're like, they took all my blood.
All of it. I mean, they one vial after another. I was astonished.
There's a lot of tests. So the routine testing, there's logic for each thing that we do, but there are several tests that get ordered.
Okay, so that first appointment happens, let's say, roughly the 8-week mark.
Yes.
And you go in there, and let's talk about the first automatic blood panel initially. So I guess there are a couple of first. There's the first blood panel where you're told outside the lines on a pregnancy test that you are indeed pregnant, and it's measuring for hormone levels.
Well, sometimes we do that, and sometimes we don't.
Okay.
So if you come in and you've done a home pregnancy test, and we do a urine pregnancy test, and that's positive, and we usually do an early ultrasound, and if your ultrasound looks normal, we don't do a blood pregnancy test.
Okay.
Now, if you come in and you've had bleeding, or there's some other concern, or say you think you're pregnant, and the test is positive, but we don't see anything on your ultrasound, then we're more likely to do the blood pregnancy test.
Okay.
So if everything's normal and looks like we think it should, usually we just do a urine pregnancy test.
Okay.
After that comes the big blood panel.
Yes, the one where they take all your blood.
Exactly. So that includes a blood type. Blood types include OA, AB, and plus or minus, because the plus or minus has to do with your RH status. So the RH part of the test is the important part, because if you're RH negative, that can impact the pregnancy and can lead to complications.
What is RH?
So RH is a type of blood antibody, and if your baby's blood antibody is different than yours, then the blood can interact, and your maternal blood can destroy fetal blood cells.
Okay.
And that's why we test for that. So let's say your Rh negative and your partner is Rh positive, then your baby could be Rh positive.
Mm-hmm.
So your Rh negative blood, there's some intermingling of mother and baby blood, and sometimes the mother's blood can actually start destroying fetal blood cells, and then the baby gets anemic, and that can lead to a lot of other issues. So that's why that gets tested.
Okay. So you've got blood type, Rh positive or negative.
Right. We test your blood count to see if you're anemic. So anemia has to do with how much oxygen carrying ability your blood has. So there's a tendency for that number to drop a little bit while you're pregnant because you are creating a lot more blood cells to help provide oxygen for the baby, and because of that increased volume and increased blood cells, then a lot of times people end up anemic. So we do a baseline when you come into care.
Is anemia, is that the same thing as whenever, I remember this from science class as a kid, where you look at the lower part of your eye?
You can, and it's pale instead of pink.
Okay.
Yeah.
But a blood test probably gives you a lot better indication of what's going on in there. All right.
So we test for rubella and varicella. So rubella and varicella are infections. They're not very common. Varicella is chickenpox.
Mm-hmm.
So now that there's a chickenpox vaccine that's been in use for many years, we don't see that as much. But the reason we test for those things, because if you get those infections during pregnancy, it can have very bad effects on your baby. Most people have been immunized for those things or have had chickenpox.
Yes, or they had it
and so they're immune.
Immunity.
Right.
Okay.
So if you're not immune, then it just sort of gives us, we immunize you after you deliver so that the next time it's not an issue. But, and it's rare that really comes up as an issue, because I've never seen a case of rubella.
Mm-hmm.
And chickenpox during pregnancy is pretty unusual. But it's one of those things that we would be very concerned about it if you got chickenpox while you're pregnant.
Well, and so yes, it's unusual because the chickenpox vaccine has been around long enough that you're going to see it in young kids. If you had another child, say, who you're not likely to have that kid come home with chickenpox if they've been vaccinated.
Exactly.
What about shingles? It's the same, is it the same virus?
It is the same virus.
Is there a risk of exposure to shingles if you're not immune to chickenpox?
There is some risk.
Okay.
Yeah.
And is it just one of those things that if you suspect you've been exposed to it, do you call your doctor and
Absolutely.
follow up from there?
Yeah.
Okay.
But, unless your intimate partner has shingles, it's probably not going to be an issue.
Okay.
So shingles is not something that's transmitted from a distance.
Mm-hmm. Okay.
Okay.
So we've got chickenpox and rubella is, what's rubella?
German measles.
All right.
Right.
So if you need that for a trivia night, it's a good one to have along the way. It actually was a trivia night question. We were lucky enough to have a pediatrician at our table who knew all of these, by the way. All right, so rubella, chickenpox, what else do we have?
We screen everybody for syphilis. It doesn't come up very often, but syphilis is another one of those infections that can cross the placenta and cause devastating effects in your infant. So everybody gets screened for syphilis. We also do a urine screen because urinary tract infections are common during pregnancy, so urine is collected. So we screen for hepatitis B. Most people have been immunized for hepatitis B also, but occasionally we find patients that are positive, and that's another infection that can be transmitted to your baby.
Okay.
If you have hepatitis B, if you are positive for that test, then after delivery, they automatically treat your baby to prevent the baby from having hepatitis B. Most people who have hepatitis B now are people who are immigrants who didn't get immunized, and it's fairly common in certain countries.
Okay.
Generally, we do HIV screening because, just to make sure you don't have HIV. That's another thing that doesn't come up often.
We did talk about this a little bit a couple of weeks ago, and I think it applies also to the syphilis and HIV tests. Those are, first of all, uniformly ordered. I think it is kind of shocking to see that on a blood test as you're going through the list. I think mine just said maternity panel, so I didn't see everything, but then when they called afterwards, they said you're HIV negative. I was like, well, I'm grateful to know that, thank you. Didn't realize it was being tested, and we talked about it in my appointment. I just, there's a lot of information there, but the HIV infection and syphilis as well, and you had mentioned it was syphilis, that there is a lot that can be done now to prevent transmission
Absolutely.
in the event that it exists in your body and you have no symptoms.
Right.
And it can protect the baby.
Exactly. Patients who are HIV positive, if they take the medication throughout the pregnancy, then their babies are born without HIV. So it makes a huge difference. And syphilis is treatable. I mean, it's penicillin. That's easy.
Mm-hmm.
So the infections can be devastating if we don't catch it, so we screen everybody.
Mm-hmm. Okay.
It's recommended that we screen for chlamydia also. Hemoglobin electrophoresis is a test that is done to detect sickle cell disease, sickle cell trait. There are a few other hemoglobinopathies that can lead to low blood counts, and so that's also routinely done.
Mm-hmm.
Sometimes we test for thyroid disease, but it depends on your history. And sometimes we do early diabetes screening, also depending on history. People who have a history of diabetes in previous pregnancy, for instance. Patients who are significantly overweight, a lot of times we'll screen them early for diabetes. That's a recommendation. Sometimes patients, we screen them in the first trimester and find out that they actually have pre-existing diabetes and just didn't know.
Mm-hmm.
So there are other tests. It just depends on your past medical history.
Okay, so that's the first big wash that everybody gets.
Exactly.
And this is a good time to mention also, if you have any questions, you are welcome to add them to the comments, and we will pose them as we're able to Dr. Turner and rely on her expertise to walk us through all of this. So we've got that first blood panel out of the way, and I think it was, I do not care for needles, and I just kept looking away and I was like, are you done yet? Are you done yet? And it was, I think, 3 or 4 vials, and then there was the urine sample.
Right.
So, and then every time that, at least in my situation, my physician's practice, they do urine samples at every
visit
appointment,
Yeah,
and
that's
that is
standard.
For
so we're
UTI.
looking for signs of infection, but also looking for sugar in your urine, because that may mean that you're diabetic.
Mm-hmm.
And looking for protein.
Okay.
Because protein, can be a sign of kidney disease, but it's also associated with preeclampsia, which typically doesn't develop until later in the pregnancy, but it can develop at any time. So preeclampsia is a pregnancy disorder which is elevated blood pressures associated with protein in the urine.
Okay. So I'm trying to walk through these as chronologically as possible. I'm going to have to rely on you to keep me on track. So we've got that first panel that everyone gets, and then there are a number of optional panels. And I know one question that sticks out in my mind that we were asked at the first appointment, there were several having to do with family history about heart disease and cancer, and whether anyone in either of our families, if we had any, who were descendants of any Ashkenazi Jews.
Right.
And what is the reason for asking all of these questions?
So, for instance, with Ashkenazi Jews, there's an increased genetic predisposition to a whole group of genetic disorders. So it includes cystic fibrosis and, oh my God, what's the...
There are so many. I do not understand.
Right, so there's a panel for that.
Yes. And it's highly unusual. I mean, it's a very small population, correct?
It's a fairly small population. Yeah, I didn't bring my cheat sheet. There's a panel, so, but there's definitely a much greater risk of those things in that population. And so you ask about family history. In certain places like Mediterranean people, there's a higher incidence of certain hemoglobin differences, and so that's where the hemoglobin electrophoresis comes in.
Okay.
Well, just like with patients of African descent, sickle cell is a hemoglobin issue, and so it depends on those things. And part of the discussion then also is your age and how old you'll be when you deliver, because if you're going to deliver at greater than 35 years of age, 35 or older, then you're considered advanced maternal age, and that used to be the cutoff for genetic screening, although now, because we have non-invasive prenatal testing, younger people get genetic screening also all the time.
Well, it was so interesting because I am right at the cusp of that. We talked about this again a couple of weeks ago that I'm 34, so and will deliver. I will be 34 still, so I'm right on the brink of that 35, which is somehow a magical number in medicine.
Right.
So a number of the tests are not automatically covered through insurance,
Right.
but they exist as options. What are the optional tests that you lay out for patients at that first appointment?
So, the optional tests include. Let's go to the oldest ones and move forward.
All right.
So the old ones include, for instance, a quad screen.
Mm-hmm.
So this is a blood test. It screens for Down syndrome. It screens for trisomy 18 and 13. It's a blood test. It's done in the second trimester, so it's generally done ideally at 16 weeks or later, so 16 to 20, maybe 22, but it's done in the second trimester. The limits of the test are that there's a lot of false positives, and we have to wait until you're in the second trimester to do it. So if we find a problem at that point, then it's later in the pregnancy. So quad screen. In the olden days, before we had all these newer tests, if you were over 35, we would offer you a first trimester test called a chorionic villus sampling. So that's a sample where they put a little catheter through your cervix to get a little bit of tissue, and then they look at the chromosomes that way. So obviously that's not a terribly popular test because it's invasive. It's safe.
You're not selling it so well here.
But that's what was available, you know. And then the other choice is amniocentesis. So with amniocentesis, they actually take a long needle and poke it in through. They do this under ultrasound guidance, but it goes into your uterus and takes out some amniotic fluid, and they check the chromosomes that way. That's done really rarely these days because we have all these other newer choices. But before all the development of these newer choices, that was what was available. So then moving forward in time, the next test that was developed was the first look. So with the first look, they do a first trimester ultrasound looking for certain characteristics on the fetus. They measure this fold, this thickness at the back of the neck of the fetus, and they look to make sure everything else looks normal. So they take that information and a blood test result and combine that information to come up with a risk number for that patient. So that's called a first look, and sometimes they would combine the first look result and then also do the second trimester quad screen as sort of a follow-up. After that came the non-invasive prenatal testing, which has been available for a few years. This is the newest one, though. So the non-invasive test also tests for trisomy 21, 18, and 13, and it can also tell you the sex of the baby.
And that one, correct me if I'm wrong, you can get fairly early.
Yes, it's first trimester.
Okay. And that was whenever we were given, all of these brochures to look at and counseled on all of the different possibilities, rare though many of them may be, that was the hardest decision to grapple with, was what do we do? Why would we do it? It's not automatically necessary.
Exactly.
And how do you counsel patients who, you're assuming too, and we talked about this a little bit before we started, for someone who was delighted to be pregnant, it was a hard decision. For someone who is maybe struggling a little bit with coming to terms with that, I suspect it would be even harder. How do you walk your patients through these decisions early on?
First you tell them what testing's available and talk to them about what these results would mean. Like, what does that mean if your baby has Down syndrome? One test that I forgot to mention in the quad screen is that it also tests for neural tube defects. So neural tube defects are things like spina bifida. So I think that all of us encourage patients to do at least a minimum of testing. I think the minimum testing would be a quad screen, because that's a tube of blood, and I always feel like, and I ask the patients, if this was a problem that your baby had, would you want to know that ahead of time, or would you want to be surprised at the time of delivery?
And there are some now too that kind of our benchmark, or at least in my mind, has kind of been, if there's something we can do about it now, meaning there are some treatment options to explore for, say, some neural tube defects.
Exactly.
It's worth at least having the knowledge.
That is always my argument. And things like with neural tube defects, you really need to be prepared for that. We need to send them to the pediatric neurosurgery people. They get involved in their care and the plan for delivery, so that, like once I had a patient whose baby had a spina bifida. She was getting her care at St. Anthony's. Well, she transferred to us because she wanted to deliver at Barnes because she was next door to Children's, which made total sense. So then we had her set up appointments with the pediatrician, the pediatric surgeon, and so all that was already in place by the time she delivered, which is, to me, what you want to do. You don't want to be surprised because it doesn't give you the optimum care at that point. You know? So when you're talking to patients, you're really asking them, what are you going to do with this information? You know, some people choose to discontinue the pregnancy if there's some major thing wrong. There are things that we can find out that these babies don't survive. These babies with trisomy 13 don't survive. So, you know, would you want to know that ahead of time? I think you would. Not everyone does. People opt to not do any testing.
Well, and it's so interesting too with the trisomies, and we've seen this at Children's. I've known families who come through the fetal care center. That's the collaboration between Barnes Jewish and Children's and WashU, that they do know ahead of time that it's trisomy 13 and the other one that there are two that are fatal, correct?
Yeah,
18, okay. And then Downs is a trisomy, is 21?
21.
Okay, so it's 13 and 18, and there have been families who found out and elected to go through the pregnancy, but wanted certain measures in place. They wanted to be able to hold their baby. They wanted to be able to bathe their baby, and they were able to make those plans and have those moments with their child that they otherwise might not have. And you know, it's interesting talking to those families in the aftermath, because they will say, you know, we're so glad we knew, or, you know, and some do have, I can't think if I've ever heard anyone say they wish they didn't know. But again, I think it's a skewed sample because I'm always talking to families who opted for the testing.
Right. So the patients that I have that say, I don't want any testing, sometimes they are people who have anxiety issues anyway. And so I get from them, I would just worry about it constantly, and so I just rather not know anything. So some people take that attitude, and some patients feel like, I don't care if the baby has any of those things because we're going to continue the pregnancy and we'll just see what happens. And we get a lot of that too. So I always argue for more knowledge is good.
So, but the results, I think, the one thing that has been reiterated to me time and again is that the results do not mean that you have to choose one certain thing. I mean, if you come back, it means that you do have options to consider afterwards.
Right. And the other thing I tell patients, for instance, if we found out that your baby has Downs, when we do these tests, even if it's positive, that's not absolute. There's no perfect test. So because the test is positive, like they always tell people, don't do anything based on one test. So if your non-invasive prenatal testing is positive, then they're going to suggest that you do an amnio, because that's really more clear cut and more definitive. If your baby has Down syndrome, there's all kinds of support groups, there's all kinds of information to find out ahead of time. To me, it's a way for you to be prepared, because now you know.
And it's an incredibly supportive community too. There are so many groups out there that we interact with regularly who reach out to families who are about to begin that journey and are able to help them understand a little bit better what is ahead. And it's nice to hear that not only from a physician what's going to be encompassed in your medical care, but also to hear from other parents who have been through it, see the joys that they experience every day, and to understand that yes, life is going to be different than you expected, but there are going to be a lot of other great joys along the way, which is, it's, I think, somewhat at least reassuring as you're preparing. So we've got all of those tests, which are obviously very weighty in the decisions you need to make either before or after. But there are also, is that the full gamut of the early prenatal, or are there more that?
That pretty covers them. That covers it.
And I also wanted to note that when you were talking about the high rate of false positives, so to reemphasize, there are tests that you do beyond that if it is a positive, so that you have greater degree of certainty going into the duration of pregnancy.
Which then also brings up the ultrasound, which is sort of the next testing that's done. So depending on which test you choose, like if you decide to do a first look, that includes an ultrasound. A CVS or an Anemia, there's ultrasound involved in that. But just routinely, typically people get a routine ultrasound between 18 and 20 weeks. At that time, they're looking also to see if there's anything unusual about the baby. And if they see something suspicious, they will usually talk to you about whether you need to get some testing done and give you those options at that time. The other thing to mention is that if you are of advanced maternal age, we'll usually send you for genetic counseling so that they can go through all of your risks. And that's more likely the older that you are, because your risks go up as you age. But the genetic counselors really will sit down and go through your whole family history and talk to you about all of your risks and your risk because of your age and all of the tests that are available. And then you can decide with them which one that you want. But use of that sort of depends on your provider and your age and the situation.
And so that first ultrasound typically that happens around 18 to 20 weeks, you said, is that also called the anatomy scan?
Yes.
Okay, because I was going to say, I hear a bunch of my girlfriends who have been through this, they refer to that as the anatomy scan. So I know that the appointment is scheduled, they say to bank on a couple of hours, so it's not a quick snap a pick and go.
No, they are looking at the baby from head to toe. So they are measuring the bones, the head circumference, the abdominal circumference, looking at the organs, looking at the brain. They are literally looking at the baby from head to toe.
And it's incredible. I mean, I've seen some of the pictures that have come out more recently, how much detail you can snap.
What's really incredible is how this has changed over the years. Because when we did ultrasound when I was in medical school, I mean, you couldn't see anything but like the skull, and now it's like you can see facial features, and it's amazing.
Have you seen? It's an interesting question, and even the last say 10 years, have you seen a dramatic increase in the sharpness of the images you're able to capture?
And sometimes they use 3D. It just depends on the situation.
Do you have to wear glasses for it? The 3D glasses? Probably not. So you have the anatomy scan followed by, and then after that, I know we do see families, again with the Fetal Care Center at Barnes-Jewish and St. Louis Children's Hospital and Washington University, that we do see families for after that 20-week ultrasound who are referred to us for different follow-up tests. So they'll refer as necessary for additional.
Sometimes they may pick up a heart abnormality, and those patients a lot of times will go to the Fetal Care Center. They give them referred to Children's for a fetal echocardiogram. If there's something substantial that needs follow-up afterward, they arrange for them to see the pediatrician. So exactly.
And it is so amazing to me, and you probably get a little bit more advanced look at the heart than there's a Doppler, I'm not gonna lie, sitting right over there that I was trying to make work right before Dr. Turner came in. It didn't. But that you can learn so much about your baby's anatomy before it's even born now, which is so extraordinary to me, that you can do so much more than hear a heartbeat. But at the same time, I fully anticipated going to this experience that every time we went to the doctor, we were going to see a picture of the baby, but you don't do that. It's just that, I mean, unless I guess it's necessary.
Exactly.
So
we typically do that anatomy scan, and then scans after that are done depending on the situation. So if, for instance, during the course of your care, you haven't gotten to this part yet, but once you get to 20 weeks, we're actually measuring your uterine size. We call it the fundal height. And so when you're 20 weeks, your fundal height is supposed to be about 20 centimeters, and then it goes up accordingly. So we're measuring that to document that you're growing appropriately. If you're not growing appropriately, if the baby's small, or if you're bigger than normal, that gets you another ultrasound. Because then we're looking to see, is the baby big? Do you have too much fluid? Is something else good? Do you have fibroids? Is there another reason for that? Or if the baby is small, that's really important, because if the baby's growth is restricted, that can lead to problems down the line.
Okay. So unless you need more than a tape measure, that's getting a tape measure and a Doppler most of the time?
Yes, that is usually the basic exam.
All right.
So sometimes we get many ultrasounds, and sometimes you only get one because you're super normal and everything looks fine.
And that's the way you want it to be. You don't want to have a reason to look every week. So we've gotten now through, let's say, 20 weeks, I think we were, and now we're wading into completely unfamiliar territory for me. So I do know that everyone talks about the sugar drink.
Right. So
which happens around what time?
Between 24 weeks and 28 weeks. So everyone gets screened for diabetes, because diabetes in pregnancy is unpredictable. Some people are more at risk. People who are substantially overweight are more at risk. People who are over 35 have a higher rate of gestational diabetes. So everybody gets screened. And when you do the screening, you have to drink a 50-gram cup of sugar drink. It tastes like soda that they left the carbonation out of.
I was told drink it as cold as possible. You can't have it over ice, I guess, or you're not supposed to. Get it as cold as possible and drink it as fast as you can.
Right. It's not that bad. Everybody talks about it's not that bad. I mean, when I was pregnant, I was like, oh, this isn't that bad. People made it sound like it was castor oil or something. I mean, it's sweet.
I am grateful to hear that. Well, you have to say at this point, if only it tasted like ice cream, we'd be in great shape.
Right.
But I think I will say that about a lot of things in pregnancy that I've heard. I think a lot of it is built up, at least in our own minds, to be a little more dramatic than
people help you, though.
Hopefully,
women help you because they love to tell you how bad things are. That's one of my pet peeves. Pregnant people telling other people who've had babies telling pregnant people, "Oh my God, it was so horrible." It's not. Most things are not that bad.
I figure it can't be that bad if we've continued to do it after
doing
all
it over
of
and
these
over
years.
again, right?
Yes, and I look at the number of people who have 3, 4, 5 children, and I think, well, there's got to be a reason they keep having them. So.
But I do say people have selective amnesia. That's why people have more than one child.
Which I'm okay with. You know what? If I forget it all afterwards, all of the bad stuff fades away. That's perfectly fine.
As soon as we put the baby in your arms, all that disappears.
Well, that sounds like a great drug as far as I'm concerned.
It really is.
So you've got 24 to 28 weeks. We have the glucose test.
Right.
And
so you drink it, and then you have to wait an hour, and then you get your blood drawn.
Okay.
So it's looking at how you're metabolizing the sugar.
Okay, so honestly, I had it in my mind that you were hooked up to a machine and on a treadmill or something, but it's just a blood test?
It's just a blood test.
Okay, good to know. All right, so just a blood test.
So also, though, when we do labs at 28 weeks, we also do another blood count to see if it's drifting down, just in case we need to add more iron to your regimen. And then we usually do a urine culture at that time, too. And then if you're Rh negative, we repeat that testing. Okay. So those are the things done at that part of the pregnancy. And then after that, there's really very little left.
So after that, at what point does the third trimester technically begin?
28 weeks.
28 weeks. So in the third trimester, are you just it's
you're
just a
kind
feeder
of
and a grower?
cruising. Yeah.
Okay.
You know, sometimes we'll do another blood count later in the pregnancy, but then the last test we do is a Group B Strep culture.
And that is, someone talked about this a couple weeks ago. Can you explain what that is?
So Group B Strep is a common bacteria that some people are carriers of. They don't usually get any symptoms from it. But the issue is that if it's present in your vagina when you deliver vaginally, then the baby can pick it up and it can cause serious infection in the newborn. So everybody gets screened. So it's just a swab down there,
Okay.
and it's a culture that we send off.
Okay.
So if you're positive for Group B strep, then you get IV antibiotics when you come in labor.
And are there any other tests that you ordered in the third trimester that would typically be indicated?
Not usually. That's pretty much it.
Wow, fantastic.
Let's talk about what happens if you fail that first glucose test.
Oh, good question.
Yeah. That's a good point, because a lot of people
What
do.
does happen? Then do you get the treadmill and the funny machines?
No treadmill, but
Okay.
you get to do a longer glucose test. So you get to drink twice as much of the stuff.
Uh-huh.
And then, so they draw your blood before you drink it, so there's a fasting. You drink 100 grams of the glucose, and then you have to get your blood drawn 3 more times. So it's 4.
So 3 more times.
So you get your blood drawn, you drink the stuff,
Uh-huh.
you wait an hour, you get your blood drawn in 1 hour, 2 hours, and 3 hours.
Okay, and then they measure. And what if, okay, say it's still, are we looking for positive at this point? If it,
Positive would be bad.
bad, okay.
Right. So what we're looking for is values over a certain amount.
Mm-hmm.
2 abnormal values out of the 4, you get diagnosed as gestational diabetic.
Okay, and what does that mean?
That means that your blood sugars are too high. Now, having said that, our first move, once we get the abnormal 3 hour, is to have you start monitoring your blood sugar.
Mm-hmm.
So you get a glucometer.
Is it the finger prick?
That's the finger
Okay.
prick. We want you to do it before you eat in the morning, and we do it after meals, so that way we know if we really have an issue.
Mm-hmm.
Sometimes we do those and your blood sugars are pretty close to normal, and we put you on a special diet, a diabetic diet, and then your blood sugars are normal.
Okay.
If you're lucky, that's all we have to do. Sometimes we have to put you on medication.
Mm-hmm.
Sometimes you have to use insulin. So it just depends on what your blood sugar levels are when we're doing all that testing. There's a lot of testing because we really want your blood sugars to be well controlled. If your blood sugar is too high, then your baby's blood sugars are too high. When your baby's blood sugar is too high, they tend to get fat, and sometimes they don't fit when you want to deliver them, and they won't come out. Or the other issue is that after they deliver, if their blood sugars have been too high, then once they deliver and you're no longer feeding them through the placenta, their blood sugars can get very low, and that can be a major problem.
Okay, so backing up before, I have a couple of follow-up questions to that, but is there a way to prevent? Are some people just going to get gestational diabetes, or
Yes.
is there a way that you can prevent it?
Some people are just going to get it, but if you optimize your health before you get pregnant, that helps.
Mm-hmm.
Meaning a normal body weight, having a normal diet. Some of our patients, let's just say they're carb-centric, and
What's wrong with that, I ask you?
so, they tend to have higher blood sugars.
Mm-hmm.
So good habits in general, being a normal weight really helps, because being overweight is a huge risk factor.
Mm-hmm.
You can't do anything about your age, but you can do something about that.
And do we have another question,
We
Jenny?
do. Jocelyn is asking, she said she has had gestational diabetes with her first pregnancy. Is she automatically going to get it if she has a second pregnancy?
No, it's not automatic, and we would test you early to see if you do. But no, sometimes people have it in one pregnancy and not in the other. Of course, when you come back the second time, we're testing you a little bit more frequently to make sure. Because if we do it once and it's normal, but we know that you had gestational diabetes before, we're that much more worried that maybe you really do.
Mm-hmm.
And so usually we're going to repeat the test.
And then if someone has diabetes independent of pregnancy and becomes pregnant, is it similar? Is that just a whole different ballgame?
It's a whole different ballgame, because
Okay.
if you're already diabetic, then you're diabetic.
Okay.
And I guess we shouldn't say a whole different ballgame, but you're still testing, you're still monitoring your blood
Mm-hmm.
sugar, but how we're managing it is different, because usually those people are going to be on medication from the beginning, usually insulin.
And I am assuming with gestational diabetes that it goes away after the baby is born.
It does, but it does make you more at risk for diabetes when you're not pregnant.
Okay.
So the rule is that once you deliver, we're going to repeat your testing after your 6-week postpartum exam to make sure that you've gone back to normal. And then even after that, sort of always be wondering if you have that issue and be testing you more frequently, for instance, than somebody who's never been diabetic. So it's the kind of thing where we might check your hemoglobin A1C when you come in for your annual exam because we know you have this history.
Okay. And before we let you go, there is, since we talked about whether or not it goes away after pregnancy, we've had a tendency to stop the conversation at the 9-month mark at this point with delivery, but there is a whole part of obstetric care that extends well beyond, or several weeks beyond, the delivery of this baby.
Sure.
So are there tests that continue post-delivery, or for the most part is at that point checking the physical body and making sure that everything is readjusting?
Right, it's more checking your exam. There's not a lot of testing done afterward.
Okay.
Although I should say that does depend on, for instance, if you have gestational diabetes or if you have gestational hypertension or some issue like that. But for normal patients, usually, and when you're in the hospital after you deliver, you usually check a blood count to make sure that you didn't lose an excessive amount of blood at the delivery. And if that's normal, when you come for your 6-week checkup, we don't usually do labs.
Okay, and you mentioned gestational hypertension. I keep saying you're almost ready to go, and then there's one other question, but does that go back to the blood pressure checks at every appointment?
Yes.
And is you're measuring for high blood pressure?
Correct.
Okay, and is there a point at which you tend to see blood pressure spike? I know that, I think it was, I heard in second trimester it tends to be lower?
Correct.
Or is it?
So that's true even in people who have chronic hypertension. So some people have hypertension coming in to prenatal care. So the dropping, the fact that your blood pressure sort of normally drops in the second trimester is really noticeable for them, because a lot of times then their blood pressure is normal and they don't have to take medication at that point. And then a lot of times it'll go back up in the third trimester and we might have to restart medication at that point.
And when you're monitoring blood pressure in, let's just say the third trimester as pregnancy progresses, and it becomes higher, is it something that you are able to treat generally with medication, or how do you go about determining next steps there?
A lot of different factors. So we do some blood work. We do blood work looking at your kidney function and whether you are spilling protein in your urine. If you have protein in your urine, if it's enough of a quantity, then that puts you into the category of preeclampsia, and then we have to think about delivering you, because that can be very serious illness and it can lead to kidney failure and stroke and all of these bad things. So it really depends on how high your blood pressure is and if your labs are abnormal and do you have protein in your urine and all of those things. Sometimes you just have some elevated blood pressure and nothing else, and we'll just watch you, because we want you to be pregnant as long as possible, because that's better for your baby. But it depends on how high your blood pressure is, and sometimes we do use medication, but that's usually more in people who have chronic hypertension anyway. So.
Okay. So in 30 years of treating patients, is there one piece of advice you give everybody who comes through the doors? It's probably to chill out, but we'll go past that.
That's true. Pregnant people, that's very true. One piece of advice. Well, first of all, I try to get people to get as healthy as possible before they get pregnant. I think that's just so important, because being overweight is a huge problem. It just is. It increases your risk. They have an increased rate of C-section, increased gestational diabetes, increased gestational hypertension. It's just overwhelming. My other advice to people is not to listen to everybody who talks to you while you're pregnant, because most of the time the information they give you is incorrect. People come and go, my grandmother said I shouldn't reach my hands over my head because it'll strangle the baby. I mean, every day we get one of these old
You should
wives'
keep a
tales.
notebook. I was going to say, that's a good one.
And I tell patients, just, you gotta ignore, there's a lot of noise, you gotta ignore people, because really, people get all frazzled because they're getting told all this incorrect stuff. So my thing is, ask us, you have an issue, talk to us about it. Don't talk to your grandmother and your cousin and your best friend and all of these people who are telling you factually incorrect information.
It is amazing the number of questions I've asked of OBs, and they've looked at me and said, you're fine. You're pregnant, you're not sick.
I say that a lot too.
I think probably the thing I have heard most frequently.
Yeah.
So, well, thank you so much for joining us. We really appreciate it. Jackie Turner
You're
with
welcome.
West End OBGYN. Thank you for joining us on From Belly to Baby. I swear I'm going to get it soon. I need to practice this in front of a mirror or something. We will be back next week to talk about high-risk pregnancies. So if you have any questions, post them in the comments today. We'll be sharing a little preview next week where you can share questions as well, and obviously you can ask live too. We'll see you then.